Qualitative platelet disorder, the primary function of platelets are addition, aggregation, activation, secretion. Defect in any one of these functions will result in increased tendency to bleed. Qualitative platelet disorder is a disorder affecting the structure or function of platelets. Excessive bruising and superficial bleeding in a patient whose platelet count is normal suggests an acquired or congenital disorder of platelet function. Common cause of QPD include the missing or defective protein on the surface of the platelet membrane or abnormality in the platelet granules. Patient with this disorder will have adequate number of platelets but poor quality of clotting. In clinical manifestation of bleeding disorder can be divided into two broad, superficial bleeding and deep tissue bleeding. In superficial bleeding, we have petechiae, epistaxis, or gingival bleeding. It is associated with platelet defect of vascular disorder, while the deep tissue bleeding have hematomas, hemarthrosis, and associated siya with clotting factor deficiencies. Qualitative platelet disorders characterized by prolonged bleeding time and normal platelet count. Qualitative abnormalities changes in platelet function. Disorder of platelet aggregation have Lanzmann thrombasthenia and hereditary fibrinogenemia. Disorder of platelet adhesion have Werner-Zoller syndrome and von Willebrand disease. Disorder of platelet secretion have storage pool disease and thromboxane pathway disorder. Lanzmann thrombasthenia is a disorder of platelet aggregation. GT is inherited as autosomal recessive. Genetic mutations are distributed widely over ITGA2B and ITGB3 genes present on chromosome 17. GT have deficiency or abnormality of the platelet membrane glycoprotein GP2B3A complex. This GP2B3A complex, a membrane receptor capable of binding fibrinogen, von Willebrand factor, fibronectin, and other adhesive ligands. In neonatal period of infancy in GT, occasionally with bleeding after circumcision and frequently with epistaxis and gingival bleeding. Hemorrhagic manifestations include petechiae, purpura, menorrhagia, gastrointestinal bleeding, and hematuria. The severity of the bleeding episode seems to decrease with age. Historically, patients with GT have been designated as type 1 or type 2. Individuals with type 2 disease have more GP2B3A complexes. Patients with type 2 disease are less affected by abnormal clot retraction and fibrinogen binding than type 1 disease. Diagnostic: platelet count normal, platelet morphology normal size, bleeding time prolonged, platelet aggregation ADP decreased, no platelet aggregation, histocity is normal. Bernard-Zoller syndrome is disorder of platelet adhesion, inherited as an autosomal recessive disorder in which the GP1b95 complex is missing from the platelet surface or exhibits abnormal function. GP1bA is essential to normal function because it contains binding sites for von Willebrand factor and thrombin. Infancy or childhood. Rare disorder of platelet adhesion that usually manifests in infancy or childhood with hemorrhage characteristic of defective platelet function, such as ecchymosis, epistaxis, and gingival bleeding. Diagnostic for Bernard-Zoller syndrome: in platelet aggregation, histocity is decreased because the lack of response due to the lack of GP1b95 complexes and inability to bind von Willebrand factor. Giant platelet syndromes. In addition to BSS, there are several other inherited syndromes in which patients exhibit large platelets and thrombocytopenia. The exceptions may Haglin anomaly, which there is an abnormal microtubule distribution, Epstein syndrome, which platelets are spherical and have a prominent surface-connected canalicular system. For most of these syndromes, the cause of the large platelets and thrombocytopenia remain to be determined. Disorder of platelet secretion, storage, pull, and release reaction defect are the most common of the hereditary platelet function defect, present with mucocutaneous hemorrhage, hematuria, epistaxis, and spontaneous bruising. Storage pool disease can be related to defect of the dense granules or defect of the alpha granules. Dense granules deficiencies have Hermansky-Pudlak syndrome, Chedak-Higashi syndrome, Wiskott-Aldrich syndrome, thrombocytopenia absent tragus syndrome, and alpha granules deficiency have gray platelet syndrome. Dense granules deficiencies, Hermansky-Pudlak syndrome is a triad of tyrosinase positive oculocutaneous albinism, accumulation of steroid-like pigment in macrophages and bleeding tendencies. Chedak-Higashi syndrome is characterized by albinism, recurrent infection, and giant lysosomes in all granules containing cells. Wiskott-Aldrich syndrome, triad of thrombocytopenia, eczema, and recurrent infection. Sex-linked immunodeficiency, platelets are small and have abnormal cellular membranes, demonstrate the smallest platelet seen. Thrombocytopenia absent radius syndrome, or TAR syndrome, decreased platelet count and deficient dense granules content. Alpha granules deficiency, gray platelet syndrome, absent of alpha granules in platelets and increased vacuoles. Platelets are larger than normal with pale gray to blue-gray color on right stain. Combined dense and alpha granules deficiency, decrease in the following cellular components: platelet fibrinogen, platelet factor 4, beta thromboglobulin, and platelet-derived growth factor. Gray platelet syndrome, decrease in all aggregating agents. That's all for qualitative platelet disorder. Thank you so much for listening. This is Jenica Devesa from Section A.